Welcome to the NWAETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Well, I'd like to introduce a familiar face, Jennifer Magnani. I think you all know from our expert panel here on ECHO. And Jennifer is going to talk to us today about the Affordable Care Act. As you know, Jennifer is a social worker here in our Madison Clinic, and she's a social work supervisor and is part of our expert panel. And I'll turn it over to Jennifer.
Thanks, Brian. So we're talking today about the Affordable Care Act, which of course is one of the biggest changes to healthcare and healthcare delivery that the United States has seen in the last 40 years. With big change comes big controversy, and certainly this law is extremely political. I've tried to be very clear about where I'm pulling the data from in terms of source, so that if you have any questions about that, that's very clear. And I also want to say that I make no presumptions at all about my audience and whether you are in support or not in support of this law. So we'll start off first by talking about what the basic goals of the Affordable Care Act were when it was designed. And most of you are probably familiar with at least some of these goals. If you look at the top one, we're very much in the thick of that now, which is reducing the total number of uninsured by 25 million. In the enrollment period this year is 6 months long, and the goal is to enroll 7 million of those that are uninsured during this period. We'll talk about in a minute whether we're on track to do that. The second aspect of the goal is probably the one that had the most buy-in from the most number of people. It's the one that people found to be the most popular. That's more about eliminating pre-existing condition exclusions, also allowing the extension of children on their parents' insurance plan up to age 26. And a little bit more controversial is the affordability aspect of it. The design was to provide a floor of benefits for folks that would be affordable. And I know affordable can be defined along the political spectrum as to whether or not it's actually meeting that goal. The last 3 points really have to do with aligning care more in the primary care realms and away from specialty care, away from hospital care, and moving away from this notion of volume being the driver of profit and recouping costs for care, trying to focus it more on quality, and we'll get into that in just a minute. So I think that you all are familiar with the two coverage options that are available under Affordable Care Act. Everyone on this call is having to enroll folks into an insurance exchange. Your state may be doing that through its own portal. It may be through the federal portal that's being done, but very few states on this call are actually expanding Medicaid. Of the WWAMI-O states, really only Washington and Oregon are actually expanding Medicaid. That has some financial implications for our patients, the very poor people, the folks that are at 100% of federal poverty or less, so those earning $957 a month for one person. Those folks are left out in the cold in terms of gaining coverage under this law if the state opted not to expand Medicaid. So are we on track to enroll what the government thought that we would? Well, 3.3 million have selected a plan so far. That includes folks that have paid for that plan and are perhaps even receiving coverage at this time, but it also includes those that have selected a plan but haven't purchased it. I think that the federal government will be more inclined to release data around actual enrollment totals long after the portal closes. I think right now it's such a political hot potato that's why the data is what it is right now. But I think that the expectation was that it's going to be lower income folk, those under 400% of the federal poverty line, that will be enrolling into care, and that has borne out. As you see, 82% of those who have selected a plan, in fact, qualified for some reduction in their premium. So if you're looking at Medicaid enrollment targets, it's interesting, and I have some speculations, but I can't say exactly why this is so, but the federal government really isn't releasing a whole lot of data about how many might be enrolled. This data was broadcast on CNN, but it comes from a private firm that estimate that it was coming in around 2 million so far. And the 6 million total that are eligible would be out of states that actually expanded Medicaid. It doesn't include those that would have been eligible had in states that opted not to do that. And as we just talked about, of course, there are a number of people that will not see any relief in terms of their health insurance. Nationwide, expected to be around 5 million people that will end up without coverage because the states opted not to all expand Medicaid. And something to note, too, I think while the insurance portal closes at the end of March, Medicaid enrollments don't close, and there's no real penalty for people not enrolling in that in a timely manner. So if we drill down into more HIV-specific enrollment data, this is kind of interesting to look at too. If you look at HRSA's estimation of uninsured people who have HIV, they put it at 1 in 4, and I think that they do that in part because they're including people that are not engaged in care. But this data comes out of the Kaiser Family Foundation, and they looked really at the folks in the Medical Monitoring Project, the MMP people, and those are people that are really engaged in HIV care. So of that set of folks, people that you're seeing in your clinics regularly. Close to 70,000 people right now are without health care coverage, and the vast majority of them really would have gone into Medicaid if all states were expanding that. There's a way to move some of those folks that could have gone into Medicaid over to the insured exchange, but only above 100% of federal poverty, and so still leaves about 18,000 people without coverage. This is sort of graphically what I just talked about. So the graph or the pie chart on the left shows what if all states had expanded Medicaid, what coverage would have looked like for the uninsured group of about 70,000 people who have HIV. And the chart on the right-hand side, the light blue is the folks that end up with no coverage under the current way that states are expanding. So, like I mentioned, it's tough to know exactly with people that are not engaged in care what's going on for them, and that's in terms of managing their HIV and also for their insurance. There's estimated to be about 700,000 people that don't have coverage under or that aren't engaged in HIV care. But interesting to note, I mean, I think that there's been this presumption that people living with HIV, because the care is so expensive and the meds are so expensive, that them coming into insurance is going to overwhelm Medicaid and other systems. And interestingly, if you look at least the folks that are in care, you know, the people that were missing insurance are really less than 1% of the total new enrollees that are expected. So this is sort of an interesting tidbit. If you, Gallup did some surveying and said, hey, you know, is the total number of uninsured going down? And if you're looking at the last quarter of 2013 and the first quarter of 2014, yes, that's true. But don't take that to the bank, because the same thing in terms of numbers happened in 2012 and there was no Affordable Care Act there. So it'll be a while, I think, before we see if uninsured are actually going to come onto these plans and see some relief for their health insurance. So if we take a look now at the focus and switch to primary care, you know, why do we need to talk about that? And I think some of you might be familiar with this data. The U.S. spends a much more disproportionate amount on healthcare than do other industrialized nations. In 2009, it was up at 16% of the gross domestic product and expected to continue to escalate. Someone had told me that it was closer to 18%, but I couldn't find that verified in anything official. And Americans themselves are paying good chunks of their income for healthcare at this point. So very expensive, and you'd think, well, if you're paying a lot of money, are you getting what you paid for? Are you getting really good health outcomes? And as most of you may know, of the 7 industrialized nations, we are dead last on a lot of key health indicators. And so how do you both improve quality and drive down healthcare costs? That's a tall order. And does this law do that? When you look at the Centers for Medicare and Medicaid, they list out a number of changes that they feel will meet that goal. And one of them is to say, hey, we need to increase the Medicaid reimbursement rate for primary care visits. However, they only did that for a 2-year period. So I have heard, you know, hey, this Medicaid expansion thing doesn't work super great in rural areas where you have providers that don't necessarily want to see a lot of Medicaid patients because the reimbursement level is so low. And I don't know if escalating the rate for 2 years really fixes that. I think if you're a provider that's reluctant to see Medicaid folk, you know, seeing them for 2 years and then having to release them from your practice probably doesn't feel really great. And will that be extended? I don't know. They're trying to also provide more incentive to produce better health outcomes, and they do that by saying, hey, look, if you, the provider, and you, the healthcare system, are meeting quality and cost benchmarks, then we're willing to give you financial incentives for that, instead of incentivizing folks to do more testing and to escalate the number of visits that they're seeing folks for. There's going to be a reduction in hospital reimbursements, particularly around bounce back. If the patient's readmitted shortly after discharge, then the hospital will be eating the cost of that. A lot of the changes in other ways that hospitals are being reimbursed are also changing, and I know hospitals are particularly nervous about these changes. And they're talking too about bundling payments for both the doctor and the hospital visit, which could reduce revenues for physicians, but ties everything all together in terms of health outcomes. I think one of the positive things that you see, I think, coming out of this, is that you'll see fewer patients on charity care. And charity care really isn't insurance. Folks that have just charity for their care are left out of elective procedures or other things that might have actually, produced long-term better health outcomes. And the good news is, for your practice or for your hospital, you're probably able to recoup more dollars for their care. So this is not without controversy. Hospitals and doctors have a number of concerns about these proposed changes, some of which are already going into effect. And some of the core ones are the reimbursements under this really enough to sustain a medical practice? And the jury is still out on that as far as I can tell. Just the way things are being tweaked, I don't think people really know quite yet what that looks like long term. Some folks say that this is going to really increase paperwork requirements and increase red tape. And so more doctors may say, hey, look, I'm willing to keep practicing, but I'm not dealing with insurance anymore. We're a cash-only shop at this point. And I read some very interesting statistics around doctor job satisfaction, which you all might know better than I, but some put it at close to 50% of job dissatisfaction. With complaints being, hey, I don't want to have to see 4 patients in an hour and I'm filling out way too much paperwork and doing way too much. And so will more doctors leave the field right at the time when you need more? Because of course, as folks enter the insurance market, you need more physicians in order to serve them. And with a focus on primary care, there's definitely a significant shortage in primary care providers. So some challenges we've had here at the local level in terms of the Affordable Care Act and its rollout. I can speak most accurately about the problems with enrollment. I think the enrollment problems were very well publicized at the federal level. We certainly had them at the state level in Washington, even though those didn't get as much press. And we still have applications that are stuck by error messages. My clinic enrolled probably close to 800 folks. We still have about 70 sort of stuck in the queue, and I imagine other states are pretty similar in that. And it's really not clear at this point if we're going to be able to resolve those by the end of March when the portal closes for those. So other issues that we've seen are it's really tough for an insurance company who has thousands of new enrollees just coming on to their plans for them with a quick turnaround time to be able to issue the cards, for them to update their computer system. So you had folks showing up January 1 ready to pick up their medications, which is fabulous, but no one could confirm their coverage. And so that created delays and lots of running around and who's paying and how do we confirm things. So it certainly created some problems that could have been anticipated, but were also hard to completely get rid of in advance. Other things that your pharmacist might have seen, lots of prior authorizations for drugs, lots of paperwork being completed by physicians, trying to get all that stuff done. We've had issues with formularies. Some of the very new HIV drugs aren't necessarily on the formularies yet, and so who's going to pay? And some of these plans also have shuffled some of the high-dollar, newer HIV meds over to specialty pharmacies. And so people that have been filling at the same location for forever now have to travel someplace else or receive their meds by mail or do something different than they've done for years, and that created some disruptions. Something that we won't be talking about a whole lot during this talk is the Ryan White question. And of course, no one really knows what's going to happen exactly with Ryan White given the Affordable Care Act. But I think if you're a clinic or a case management agency or some other type of provider who uses a lot of Ryan White dollars, I think you're probably a little bit nervous right now as to whether or not that money is going to be sustained. So just some questions to kind of leave you with. There's some evidence to suggest that people with HIV were kept out of care in part because of the cost of care and they weren't sure that they could get insurance. There's not really clear data on how much of an impact. It's probably a factor, as are many other factors, in getting people in the door. But since now people have insurance, what will be the uptake in new clients? No one really knows. The question about Ryan White, what is that going to do? And how do agencies survive moving forward if they don't have Ryan White dollars? And of course, the last question about the provider shortage. Is that going to get better under this? Are the investments in primary care and improving the access to primary care, does that result in an ongoing shortage, or is that actually going to get better over time?